Hi everyone, my name's Christine Stanley. I'm the CLIA medical director for a company called Q&A Diagnostics, and I'm the head of the clinical lab strategy at WuXiNextCODE. And I'm going to talk to you today about the integration of the Face2Gene app into the WuXiNextCODE clinical sequence analyzer, and how the utilization of phenotype helps us to do variant prioritization and clinical genetic reporting, and the importance of that in that process. So I'm going to go over evidence-based variant classification very briefly, and then we'll go into the concept of personalized genomics and a revisible report, and then how do these digital tools enable us to do that. So there's been much ado about ACMG variant classification at this conference. The ACMG put out in 2015 standards and guidelines for the interpretation of sequence variants in order to align genetic diagnostic testing laboratories in their interpretations and classifications of variants. Variant classification is broken down into 5 categories, which is really like 3 categories, because as far as clinical patient management goes, benign and likely benign is treated very similar. Pathogenic and likely pathogenic is treated very similar. With whole genome and whole exome sequencing, we have a massive influx of variants of uncertain clinical significance, which casts shade on the other variant categories. And if we can't figure out what to do with these, it makes it very difficult to move forward. So we need to utilize all the tools that we have in order to do variant classification. The follow-on to the ACMG guidelines was a look at laboratories in comparison to those laboratories and how they scored variants and how the laboratories were aligned in that variant scoring. This is the 28 lines of evidence that are used for variant classification, and in this study, the frequency at which those lines of evidence were utilized. The arrows highlighting the PP4 line of evidence, which is the phenotypic line of evidence. When we look at the handful that was on the right side of that graph, they are about 7 or so lines of evidence that really, well, 11 lines of evidence that really break down to around 6 or 7 when you consider that many of them are the opposites of one another. So a very high allele frequency of a variant, and the opposite would be a very rare absent allele frequency, and then in silico predictors which predict benign or pathogenic. When you take the phenotypic, you look at the phenotypic line of evidence, it wasn't one that was utilized often in that comparison, but it really could be if we could make it better and more complete. So in the ACMG publication, to utilize the phenotype as a line of evidence in variant scoring, you really need to have high clinical sensitivity, patient has a well-defined clinical presentation, and that gene is not subject to a lot of variation. It's not a very polymorphic gene, and that family history is consistent with mode of inheritance of the disorder. So if we have quality and detailed phenotype, it's critical, really critical for even performing whole exome and whole genome sequencing. And if we do that and we have very clear phenotypic information, we can not only utilize this line of evidence in variant classification, but we can also change the weight of it potentially in help scoring variants into that pathogenic category instead of variant of uncertain significance. We get insufficient phenotype when we receive tests in the laboratory, and sometimes that's due to the age of the patient. They may be too young to be presenting with clinical presentations of disease. There's oftentimes not access to much of the genetic clinical history or patient's clinical history. So sometimes the clinical records are hard to get, and they need to order the testing prior to receiving all those records. The specialist, whoever's ordering the testing, may have a narrow clinical focus, and there may be, patient could have more than one disorder, so that can cloud the interpretation and the identification of a distinct phenotype. The disease could have a clinical progression, and so depending on what stage you're looking at that patient, that disease may not be presenting with those clinical symptoms, or the symptoms could be mild because there's a broader spectrum of phenotype associated with diseases. So I'm going to go over the personalized genomics and revisible reporting. So when we look at whole genome or whole exome sequencing, we think we're looking at we're sequencing over 20,000 genes in the human genome. But really, we're not looking at all the variants that are associated with all those genes. It's an overwhelming number. So what we do is we filter those variants based on the patient's clinical phenotype. Therefore, if what we're really getting is a personalized gene panel, variants in genes that have diseases associated with them that are associated with the clinical presentation of the patient come through the filters, and the rest stay behind. With some exceptions, that's generally how it's done. And then if you have more broader clinical phenotype, you're going to be associating with more gene diseases and then bring in more variants. So the size of that panel, that patient-specific personalized panel, is really dependent on accurate clinical phenotype. So reports right now are very static. They're moment in time. What was the clinical presentation of the patient? What did we know about the genes and the diseases associated with it? What did we know about the variants at this moment in time that that report is issued? But that's not how the world is right now. New information every day comes out on variants, on diseases and genes. The patient has new clinical information, or previously incomplete clinical information may become more complete over time. So what we really need is a tool or tools that allow us to do revisable reporting. So when you look at the patient clinical symptoms and the genetic sequence and you apply that filter to get that personalized gene variant list, then you can, if you've found a positive result, you can go look, is there any medical management, treatments? Are there agents that I need to avoid based on the clinical results? Are there clinical trials? Are there patient support groups? All these things we can do when we have a positive result. If we don't have a positive result, but there's new genetic information that becomes available either on the gene, the variant, or the inheritance of the disease, then that can go back through into a filter. If there's new clinical information that's presented, or we do a deeper phenotypic analysis, that goes back in through the filter, and then you get a new variant list. You keep going through this until you get to that positive result. So how do we get to that place? We really need the use of digital tools to get there. So right now we're really poised at this moment where we can utilize these digital tools to have up-to-date phenotypic information coming in and up-to-date variant information coming in. So we've taken the fDNA tool that's collecting the detailed clinical phenotype, and we've incorporated it into WuXi's clinical sequence analyzer in order to do that real-time variant review. So not only is when we talk about phenotypic data for the patient, we think about some of the core clinical measurements of the patient, but we can really broaden what phenotype is by bringing in other medical test results and imaging, signs, and lots of different types of digital clinical information can be imported into the Face2Gene app. And then that can be brought into as clinical phenotype information into the tool that we use to look at the genetic information. And at WuXi, that's the clinical sequence analyzer. So we'll go through a case example on how we utilize those tools together. So first, the clinician will enter the case information into the Face2Gene app. And they'll put in the image they can just take an image with the app on the phone, and put in all the other relevant clinical information, stature, weight, date of birth. Then the Face2Gene will use that phenotypic information and give a candidate list of syndromes that are correlated with the information that's brought into the app. And then that gives a list of phenotypic information, and then you can refine that based on the list that shows up. There's other clinical symptoms that may be associated with some of those disorders, and so that gives the clinician an opportunity to then refine and revise that list. And then we can select WuXiNextCODE or whatever lab you're looking to import that information into. So here we're selecting WuXiNextCODE, and we're going to bring that information into our application, which is shown here. And then we utilize our tool to look at the gene list that is associated with the patient's genetic sequence. And here, in this case, we have a Boring-Opitz syndrome shows up with the ASXL1 frameshift variant, which is a likely pathogenic variant. And we're able to do that ACMG scoring with a tool that's embedded into our application. And then we are able to see that the clinical syndromic phenotype that's associated with this patient is matching with the genetic information that we have in the application. And so for, in this case, that was a positive result that matches with the clinical syndromic list there for BOS. But you can imagine if there was a variant of uncertain significance, that clinical phenotype would be much more important in trying to classify that variant as pathogenic. That particular variant is one we would have suspected. But if we have a list of variants where we don't have much information on it, then the clinical phenotype becomes much more important. We also have the ability with digital tools to be able to reissue reports much more rapidly. So in a traditional genetic testing laboratory, there's often the, you go in and you do the whole exome sequencing, and then you have a 2-year period to have the lab reanalyze that information. And so what clinicians will end up doing is marking on their calendar, at 1 month prior to the expiration of that date, that they need to submit that request to reanalyze the patient's genetic information for all the new information that's on the gene or the variant. And 2 years is a long time to wait. If you have digital tools that are constantly have the ability to be updated, then you can keep reprocessing that information. And with a tool that's in the clinical lab, in the clinician's hospital network, they can just go in and look and see, has there been any new information, and is it time to issue a report? And it could be the week after they got the original interpretation. So really, we're at this point in time where we really can't depend on a fixed static report. We really need this ability to do dynamic reinterrogation of all the information, the clinical information, the phenotypic information, and the genetic information.